Alright, I'm Alfredo Ramirez, so as you can see, I'm going to talk to you guys about cardiothoracic surgery. So what I do, in layman's terms, I'm a heart surgeon, okay? So what is a thoracic surgeon? It's a medical doctor, right? So I perform operations on heart and lungs. Essentially anything in the chest is in my domain, okay? Every now and then we'll actually have to go into the abdomen. Commonly we're called CT surgeons, cardiothoracic surgeons, cardiovascular surgeons. You can just be a general thoracic surgeon if you only want to operate on lungs and esophaguses. And then there's a branch from our field is congenital heart surgeons, and those guys do pretty much just heart and lung surgery on infants and children, okay? So what do you need to become a cardiothoracic surgeon? So you need to graduate obviously from college or university. You go to medical school, so you already put in 8 years there, unless it took you 5 years to get out of college. By and large, you need to spend 5 years doing a general surgery residency, and then you spend anywhere from 2 to 3 years doing a cardiothoracic surgery residency. So it's a lot of training, okay? So for me, I got a Bachelor of Science in college. I started in '89, and then I went to the University of Iowa for my doctorate in medicine. Finished that in '97. I did my general surgery residency, and I broke it up into the 5 years after my first year. I spent a year in Okinawa, Japan with Trey's dad, where I saw Trey being born. And then I finished my residency, and then I went to Rush in Chicago, Northwestern, where I did my cardiothoracic surgery residency, and then an advanced clinical fellowship to do more complex mitral valve and aortic reconstructions, and I'll show you what that is. So if you look from '89 to when I finished in '07, that's essentially 18 years from when I started, when I left high school to when I finished my training. Sounds like a big daunting chunk of time, but you actually break it up into parts, right? You gotta finish college, you gotta finish medical school, and before you know it, you're done with everything. So what do we treat? Okay, so we treat coronary artery disease or blockages of arteries in the heart. If you guys have relatives, grandparents who have had heart surgery, they've had bypass surgery, if you've heard of it described that way, that's what we do. We fix leaking valves or valves that are destroyed that need to be replaced. We also fix aneurysms of big arteries coming out of the heart. We're trained to do heart transplants, lung transplants, and then atrial fibrillation is a rhythm disturbance of the heart where we can actually potentially change that rhythm. So a general thoracic surgeon, if they decide that they don't want to do any heart surgery, they can just dedicate themselves to thoracic work, which includes lung cancer, emphysema, cancer of the esophagus, reflux disease, hernias that pop up into the chest, swallowing disorders, and then what I do a lot in very young people, your age, is hyperhidrosis, people who profusely sweat from their hands, to the point where they always need a napkin or something I can do a surgery to fix that. As a cardiovascular surgeon, we do bypass surgery, valve surgery, aneurysms. We can actually do minimally invasive surgery where we do heart surgeries through very small incisions. These are some of the other thoracic stuff. I mentioned the subset from our specialties, congenital heart surgeons, and those guys, you know, anybody here could have had anybody have heart surgery here as a kid? Okay, it's pretty common actually. Holes in the atriums, holes in the ventricles. These are a little more complex, but if you've seen that name, you'll know it. So how do we differ from cardiologists and pulmonologists? Very commonly when I say I'm a cardiothoracic surgeon, people turn around and say, what's it like being a cardiologist? And I say, I don't know, I'm not a cardiologist, right? So cardiologists and pulmonologists treat their disease processes mainly with medicine, okay? So they don't operate, they're not surgeons. And it's a big misconception out there between a cardiologist and a cardiothoracic surgeon. But everything I do I affected with surgery. There's nothing that I do that doesn't involve surgery. And vice versa, I don't hardly treat people with medicine. It's not, I don't see them for chronic problems, okay? This is kind of the setup of my OR. Okay, so that's me and this is my partner here. And I normally have anywhere from 2 to 3 techs. There's be an anesthesiologist over here and there'll be a perfusion guy who actually runs the heart-lung machine, okay? It's more close up and you see how we have to operate with loops and lights so that we can see everything because everything is very small when we're operating. This is essentially my backup to anything that I do. And if I'm going to operate on the heart, I need the heart to be still, to not move. Sometimes I make the heart stop for 3 hours, 4 hours. Something has to provide oxygen to that blood for the rest of the organs in the body to realize that the heart and the lungs aren't working. And that's what that machine does. So I put cannulas in the heart and I give the blood to the machine and it spins it through, temperature regulates it, cleans it, adds oxygen to it, and gives it back to the body. So we take it out through the venous structures and we return it to the arterial structures, the aorta. They've already coming out of the heart. Now this, I don't know how we're gonna, how can we click on this so that it can play? Okay, so that's essentially what, when I'm starting to work on a case, hey, can you man that?
Sure.
Because I'll tell you when to click on that. Click on that again so I can run, please. So that's essentially what the beating heart looks like before I'm going to put it to sleep. And so these are these big cannulas. This returns blood back to the heart, and this takes blood away from it so that when it goes to the pump, it comes back oxygenated. Okay, go ahead. In order to put it to sleep, I add ice on it, and I cool that heart down. And then I put a clamp on that aorta, and the heart's going to go to sleep. Okay, so if that heart starts at about a temperature of about 98, I cool it down to about 50 degrees, so about 10 degrees Celsius. So the heart is essentially just a snow cone. What that does is it decreases its demands, okay? And what we'll see is, yeah, play that. What we'll see is that the EKG, which is normal and he's beating at 80, 90 beats a minute, will start slowing down. And so the beats get further and further apart. Go ahead, click that. There you go. And so then he's flatlined. So that heart is not beating anymore. Okay, it's just sitting there looking flaccid so that I can open it and work on it. Okay? So one of what we call our bread and butter, the most common procedure that we do is coronary bypass surgery. People come in, they're older, they have blockages in their heart. Okay? We can't do anything about these blockages. Okay? Whether they're 50%, 99%, 100% blocked, we can't do anything about it. We don't go in there and take that blockage out. But what we can do is reroute blood. And so we'll take a piece of vein from their legs and an artery from the inner side of their heart, and we'll attach it to this big artery and go past the blockage, such that when the heart squeezes and blood comes out this big artery, it'll reroute itself around, and essentially the heart is continuing to feed itself. Okay? So if you look at this is the general setup of what I look at in the operating room. These are the cannulas that I've put in. Okay? Obviously you have to split your breastbone open, the entire chest open. Okay? Click on that one. Oh, there'll be a couple more. Okay, I'll stay with me. So this is just a clip of us sewing on this tiny little vein onto the arteries of the heart. It's pretty meticulous little work. It's essentially trying to sew like something smaller than a spaghetti noodle. Okay? So we wear big magnifying glasses to operate on the heart, and you can see that the heart is not moving, it's just sitting there still. And like I said, I've put hearts to sleep for up to 4 hours, and then I wake them back up. Look again. So now the heart starts quivering. I'm done with my bypasses, and this is how I put it back together. It's a little flurry, but I basically just use little jumper cables and zap it back, and the heart will start beating again. It starts slow. Right here, it'll stop again. So then I'll have to repeat that. So then I'll zap it again, and we let it sit there and beat for a little while, and then the heart will come back to life, and then I'll slowly wean it off the support of the machine. Go ahead. So now the heart is completely now it's taken over its own rhythm. This is after we've done the bypasses and everything, and it's sitting there beating. And I watch it beat for about 10 minutes so that it regains most of its function by itself. And this is essentially the end product of what it looks like. Okay? We've attached the vein past the blockage. This is the artery that comes from the undersurface of the sternum, and we attach it there. And this is kind of what it looks like when I'm looking at it. Okay, and so now basically it's just like plumbing. We're just rerouting blood around blockages. Okay? Another thing that's a big surgery for us, it's a big emergency, what we call, the only thing that we'll generally rush into the hospital for is an aortic dissection. So normally you have a normal aorta. If there's a tear in that aorta, here proximally, if they survive the tear and it's a contained tear, they'll make it to the hospital. The overwhelming majority of people will die from this. It'll rupture and they bleed out and we can't save them. So this is a surgical emergency for us, and that's kind of what it looks like. It looks like a big, blue, enlarged artery that's very tense, and the minute you touch it with something, it'll rupture. And so you have to be very, very careful. So most patients, like I say, about 10% of patients will actually make it to the hospital. If they make it to the hospital and they make it to surgery, they have a greater than 80% chance of surviving. If they don't operate within a week, they have a 90% mortality. So essentially what it is just a big tear. So if it's a normal aorta, this is the separation of the aorta. Here's the normal inside of the aorta. People who are prone to this are people who have aneurysms or who have abnormal valves that they were born with. I think you can click on this. So you'll start seeing this destroyed artery over here, right there. And how it's pulled away from the main artery. Now the heart is completely asleep. We would actually clamped the aorta up much higher up and opened it up. I think that's it for now. Okay? And so this is what it looks like when we fixed it. Okay? So before we had this big blue ugly aorta, and we replaced it with this. Essentially this is a cloth graft. Okay? It's called a Dacron graft. And so all we're doing is rerouting flow back into what is considered the normal lumen. This torn part, we just leave it there. We come back another day and fix that. But that's kind of what it looks like. That surgery can take anywhere from 4.5 hours. I've done one that's taken me 19 hours to do, just because of how destroyed the tissues are. Oh, that's just a real life picture of what one of those looks like. But that's not my slide. So that's a quick rundown. I think we have some time for questions. If you guys want to ask some questions. Come on, somebody has to have a question. Come all the way down here. Ask me anything. Yep.
What's your yearly salary?
It's in the six figures a few times.
Cool.
What else? Anything about medicine? You know, it doesn't have to be a cardiothoracic surgery. It can be anything about medicine. Yep.
How long does the anesthesiologist like stay in the operating room the whole time?
Yep. Now they might switch out. If we're in there for 19 hours, we might get 2 or 3 of them. They're not going to stay in there as long as we do. Someone else saw something. Yep.
For a field like this, what would you recommend is a good college major?
I mean, you can major in anything for any field, and if you just want to go into medicine, you'll have your prerequisites. Everybody has, or the medical school has prerequisites. I had colleagues in medical school who were English majors. I did a double major. I majored in biology and cellular physiology, and then I had a chemistry minor. You tend to see that most people who go to medical school will have some type of science or physics or math related major. Something in the sciences. It tends to be your strong point because that's what you're going to emphasize at the beginning of medical school. So you kind of want to at least have an idea. I will tell you that pretty much everything I covered in college, within the first 3 weeks of medical school, we covered it all. So that's about how much it comes. Who else? Trey, what's your question, Trey?
Oh.
This is much cooler than what your dad does.
Yeah. Let's see. How long did it take for you to become a cardio?
18 years. 18 years. Your dad was a long track too, because he did research and stuff. Who else? Alex, you have a question?
How many times do you operate a week?
It depends. So I normally have operating days 4 days a week, and our Fridays is when I see patients in my clinic. I'll see new patients that are going to surgery or patients coming back who are recovering from surgery. Yeah?
How many people do you work with in an operating room?
My operating room can easily have probably in the order of about 15 people. Because I also have a circulating nurse. Anesthesia has usually 2 or 3 people at the top. My perfusion guy runs the pump. I have anywhere from 3 or 4 techs. I have myself. I operate with another surgeon. And normally I have surgeons who are in residency training. So it's a big group. But the lead surgeon is essentially the conductor of that orchestra. He has to keep an eye on everything that's going on.
You said that one of the operations took 19 minutes.
Yeah.
Did you get a
I went out of the OR for about 15 minutes to go to the bathroom. And to get a snack, just to eat a candy bar or something. But generally, the long operations, you normally will stay there. You don't really keep track of time. You look up and it's 2 o'clock, you look up, it's 11 o'clock at night. It's just one of those things.
When in your career did you start making profit?
Say that again?
When in your career did you start making like the big bucks?
Once I was done,
Oh, really?
done with my training. I mean, you get paid as a resident, and I got paid when I was doing my cardiac training. But essentially, once you finish everything is when you'll start seeing your numbers go up a little. What else, guys? Yep.
When you have a blockage, you said that you have to work around it. So why can't you clear up this blockage?
Because if you go in there and clear out the blockage, you make the vessel very susceptible to forming clot. Okay, you destroy the surface of it, so the body will recognize that surface as foreign, and what it does, it'll send platelets there to clot. So then blood won't go through the clot. So it's just easier to plug a bypass past that area, because when you do a bypass, all you do is you open the top of the artery, and then you sew the other one on top of it, and you've not disrupted anything on the inside. So it's less likely to clot. Yep.
Do Do cardiothoracic surgeons also deal with putting in stents and?
No, so that's cardiologists. The cardiologists do angioplasties and they do stents, they put pacemakers, things of that nature. We don't do stents, we operate. We're not in competition, but they will sometimes deal with blockages using stents. Now, some patients benefit from stents and some patients benefit from surgery. You guys done with lunch?
About 2 minutes.
Thumbs up, you guys. You're all quiet over there, buddy. What do you just want to take pictures of me?
No.
Have you ever made a mistake?
Sure. Yeah, everybody's fallible. Yeah, you make mistakes, but you try to minimize your mistakes, or hopefully it's a mistake that you can fix. Okay.
And
That's.
And
Huh?
if you can't fix the mistake?
Fortunately, that hasn't happened. A lot of the times, it's not that you're necessarily making a mistake. It's what you're working with. You know, most heart surgery are in patients that are older, so their hearts aren't as healthy. If they were, I wouldn't be operating on them. So generally, you try to fix a problem, but sometimes you can't fix it. It doesn't necessarily mean you made a mistake. It's just what you're working with. Your margin of error is very small. That's one of the reasons I chose cardiothoracic surgery. I wanted to be the type of surgeon that I was it. The only person that could come bail me out from a problem would be another heart surgeon. Okay, so generally we tend to be the guys that do the biggest surgeries, the longest surgeries. That's why our training is so long. So we are trained so that our margin of error is very small.
Other than just minimizing margin of error, why can't the training be any shorter? Like, why can't you have the maybe like residency and medical schools at like closer?
Because there's a lot to learn. And you have to kind of get to a point where you are confident as a surgeon to be able to tackle bigger things. So the reason I trained as a general surgeon is so they train me as just to be a surgeon. Okay, mostly do abdominal work, kind of chest work, breast cancer surgery work. So it takes about 5 years to the point where you have the skills to be a surgeon, and then you have to compete to go to that next level. And then I did 3 years of heart surgery because you need to do a lot of cases in order to become proficient in it. You can't just do 3 heart bypass surgeries and say, okay, now I can do it. You have to do a lot. I did over 500 heart surgeries in the 3 years that I did cardiac training. Okay, so that when you come out, you've done enough cases so that you can be able to tackle the different complexities that you'll see in your patients. Not everybody is the same. So that's why. Unique cases. In order to do that many cases, it takes time. On average, you will do 2 cases a day in training, sometimes 3. But they're long, right? I mean, they're 4.5 hour cases. If you do 2 of them, that's 10 hours a day. Sometimes you do 3. So that's why it takes longer. What else?
Do you guys ever work with radiologists or any other?
Other than them helping us, we look at CAT scans and stuff together. I mean, those guys don't ever go to the operating room. But they help us. I mean, there are support staff in the sense that we need CAT scans to be able to see it stuff. All right, thanks for having me, guys.